Okay, well, we have a lot to get through, so we will get started. Welcome, everybody. Thank you for joining us for our sixth webinar of the year. So today, we will be hearing from Dr. Carolyn Lemsky on integrated care for people living with substance use and brain injury. My name's Sarah Clark. I'm Medify's knowledge broker. I'm filling in for Dr. Jennifer Wyman, who is the webinar scientific chair and the usual moderator. So I'm very excited to be here today. Oh, there we go. Sorry about that. So I'd like to start us off in a good way with a land acknowledgement, which is of course particularly important during Indigenous History Month this month. So I'd like to acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. The Medify program office and I personally am located in Toronto on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons. Toronto is Treaty 13 territory and is part of the Dish with One Spoon Wampum Covenant. Medify is committed to reconciliation, and we recognize that the many injustices that continue to be experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. And we respect and embrace the rich cultural and traditional practices of the many Indigenous cultures that exist on these lands. And we invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation, which is, of course, an ongoing process. So a couple of notes, which will be familiar to those of you who have attended our webinars before. Please share your comments and questions during the webinar by posting in the chat box at any time. Just make sure when you're posting that everyone is selected in the drop-down list rather than hosts and panelists. That way everyone can see your comment. And then during the last 30 minutes or so of the webinar, you'll be able to raise your hand and come off mute and speak to ask your question out loud. At the end of this session, a session evaluation will be circulated for you to complete after the presentation is finished. And this conference has been accredited by the webinar has been accredited by the College of Family Physicians of Canada for Main Pro Plus and for the Royal College for Section 1 credits. The fact that Jennifer is not here this evening moderating actually gives me the opportunity to thank her in particular, along with our other webinar series committee members. So these folks have all contributed to the planning and the scientific evaluation of our webinars. And Jennifer Wyman, of course, has done a tremendous amount of the work as chair, as has Laurie Smith, our wonderful program administrator. So thank you to Laurie as well. This is our last webinar for the summer. We're going to be off July, August, and we'll be reconvening in September, and we will be sharing the rest of the lineup at some point during the summer. So we will keep you posted about that. And with that, I am very excited to be introducing Dr. Carolyn Lemsky, our speaker for this evening. So Dr. Lemsky is a board-certified neuropsychologist with 25 years of experience working in rehabilitation settings in the US and Canada. For the past 15 years, she has been the clinical director at Community Head Injury Resource Services, or CHEERS, of Toronto, a Ministry of Health and Long-Term Care funded agency designed to promote community reintegration of persons living with the effects of acquired brain injury. At CHEERS, she maintains an active clinical practice along with her administrative research and training activities. For the past 9 years, she has been the director of the Substance Use and Brain Injury Bridging Project, a research and knowledge transfer initiative funded by the Ontario Neurotrauma Foundation. Along with her partners at the Center for Addictions and Mental Health, CAMH, she has trained over 2,000 mental health, addictions, and ABI providers in basic skills needed to promote the development of more accessible addictions programming for people living with substance use and ABI. The SUBI program is responsible for initiating screening for brain injury at CAMH and the first Canadian pilot treatment program for comorbid ABI and addiction. Products of the SUBI project include a provider's training manual and client workbook. So we're very excited to have Dr. Lemsky with us tonight. And with that, I will turn it over to you.
Oh, thank you so much. It's a great pleasure to be here. Uh, I the RAM clinics in particular are an invaluable resource for the people that we serve. So it's a real privilege to be talking with this group. Um, I'm gonna be addressing this topic. I first want to start out with some acknowledgments. You heard about this, our partners, the Center for Addiction and Mental Health, and Peter Selby there has been a great advocate for this work. We owe a debt of gratitude to some folks at the Ohio Valley Center for Brain Injury Rehabilitation and Prevention. And our funding, and actually, I realize this is probably an old bio that I gave you because it's been way more than 9 years. We're on the second version of those materials, and they were funded initially by the Ontario Neurotrauma Foundation, and then the follow-ons were funded by, actually in the States, by SAMHSA and their technology transfer centers, and the National Association of State Head Injury Administrators. And I have no financial disclosures. All of the different resources that I'm going to be talking about today, in particular the toolkit and the workbook, are freely available for clinical use. And here they are. And so I'm going to linger on this a little bit. If you have interest in this and you want to kind of pull it up on your phone, almost everything that I'm going to be talking about today is represented in the traumatic brain injury toolkit. I know that one of the mandates I have for today is to talk about the intersection between substance use and brain injury, and also accommodation and some program recommendations. And all of that is in a nicely organized format. And I'll talk a little bit about some of the content from there. What might be a little bit different today is that when I was talking to Lori Smith, we were discussing the need for apparently for a closer look at opioid use, and so I'm going to focus on that in my remarks.
And I'm sorry to interrupt you, Dr. Lemsky. Can you share your presentation? I think we threw you off with having our screen sharing going.
Yes, we're seeing you.
Ah,
I don't need
I
slides.
thought I pressed share. Yeah, there's always a first time for not getting it right. Here we go. I want to make sure that it comes up. Is it sharing?
Not yet.
Oh my goodness. Do we see it now?
There we go.
Yeah.
Perfect.
Okay, so I'm going to linger there a little while longer then. So this is the QR code takes you to a website that points you to both the client workbook and the traumatic brain injury and substance use disorders toolkit. And I believe that the slides from this will be available to people who attended, so all of the resources will be available for you. So I agreed to talk about describing the intersection between substance use and brain injury, recognizing the behaviors associated with that, and identifying appropriate accommodations and treatment. This is a big, tall order for 1 hour. I'm going to give that an opioid spin, and we'll talk a little bit more about the neurocognitive impairment resulting from opioid use and overdose. It's going to have to be a very high-level overview, and if there's any questions and we have a discussion at the end, I can provide more details if that's going to be helpful. The way that I've structured this is that there's information for reference in the slides, so it may feel like I'm kind of going quickly through things, but the idea is that if you want more information, then it would be available for you. So, what I'm going to be talking about is opioid use, the impact of opioid use, overdose, and also some key strategies in addition to accommodating cognitive impairment. So I'll start out by giving a little bit of background. I'll talk about addressing or accommodating cognitive impairment or recognizing cognitive impairment as well, and then contingency management. I have not been doing well with technology today. I have a couple of videos to perhaps share. We'll see how that goes and what timing is. So I'm going to start out because I'm not the most disciplined speaker, and make sure that I make this point right off the top, which is that the steps that I'm asking folks to take when it comes to accommodating neurocognitive impairment in your practice is to learn to screen for all sources of cognitive impairment. I'll allude to very briefly how to do that for brain injury and lifetime history of brain injury in particular, and that's in the information is in the toolkit. But you want to be having that conversation and thinking about what are the possible sources of neurocognitive impairment. As we'll talk about, there are many. Recognizing it when you can't necessarily even ask about it, but what things are you seeing that might be related to neurocognitive impairment? Some simple accommodations, everything from keeping a blank paper in front of you while you're talking to clients so you can make little notes for folks and help them to focus their attention and remember what's been said, to connecting to other service providers. And I'll give a caveat with the connection here. It's not a matter of identifying brain injury and then referring to the appropriate services. The way that brain injury services were designed pretty much Canada-wide is that most of the resources are directed towards acute care and in the community, and not in the community. So a person will get a lot of follow-up after a brain injury up until maybe a few weeks or a few months into outpatient care. And then after that, the resources become pretty limited. And so there are agencies that are designed to provide community-based supports to people living in the community with acquired brain injury. But as you'll see, there's a system imbalance there. The brain injury system is really tiny. The mental health and addiction system, even though there are lots of pressures on it, is much, 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 much larger. And when you think about the epidemiological numbers I'm going to give you, if you were to refer into our tiny system, all you would be referring to is a very long wait list. So what's incumbent on us as providers is to really make the best of our resources to manage folks that come with us, that come to us, and do our best to do that within existing resources. And so that's what this is all about, is kind of a primer and using the materials to roll up your sleeves and do what you can right now, and then maybe connect with community agencies who can either provide more guidance or, in some cases where it's available, more direct services. So I'm just going to start out by saying that we're talking about acquired brain injury here. Now, most of the time I talk about traumatic brain injury specifically. And traumatic injury are injuries where there's a direct force to the head that results in a change in cognitive functioning or the functioning of the brain, at least temporarily, whether it's a brief alteration or whether it's loss of consciousness. And that is one of many different kinds of acquired brain injuries. And acquired brain injuries include things that are non-traumatic. They don't include neurodegenerative disorders or congenital or developmental conditions, but things that are acquired at some point, either in childhood or later in adulthood. And they might include CVAs, infections, tumors, toxic metabolic conditions, the impact of substance use. So we are talking in that sense about a toxic injury to the brain, and hypoxic and anoxic injuries, which will also be a topic that we're discussing today. What you're all often going to hear about when we talk about brain injury and traumatic brain injury in particular is that, well, when we want to think about the severity, it really is related to the depth and the length of the alteration in consciousness, because you have to have some of that to be considered a brain injury. So at its mildest level, it's dazed and confused. Then there's a frank loss of consciousness or an absence of responsiveness. And then coma would be on the more severe end. And for concussions, what we're talking about is a brief loss of consciousness that lasts perhaps up to about, or any loss of consciousness. Mild brain injuries are a loss of consciousness up to about 30 minutes. And then moderate to severe is 30 minutes to an hour. No caller. And the more severe injuries, like over an hour, would be coma, right? When we talk about lifetime history of acquired brain injury, we're really interested in people who have had any loss of consciousness or mild traumatic brain injuries, or multiple mild traumatic brain injuries, and I'll be explaining that. So there's a few things to remember about traumatic brain injury in particular. A concussion is a traumatic brain injury, and there is a relationship between the severity of injury as measured by alteration in length and depth of loss of consciousness, but it's not a perfect relationship. Some mild traumatic brain injuries have significant consequences. And then there are people who recover from moderate to severe brain injuries and do very, very well. So it's not a perfect relationship. But what's of real interest to, I think, this group is that multiple mild injuries do add up. And the number of those injuries and the spacing between those injuries makes a big difference in terms of ultimate outcomes. If an injury occurs so close in time that the brain hasn't yet had a chance to heal, that has a bigger impact on functioning down the road. And of course, you can think about the fact that it doesn't have to be a direct blow to the head. Whiplash injuries, blast injuries also have an impact. And the nature of the impact does vary to some degree with the mechanism. So, like a high-speed car accident is going to have more axonal shearing. So that's one kind of injury, whereas a fall might have less axonal shearing and more of a contusion. So the high risk groups for this, and for the purposes of our discussion, I'm going to describe people who are most risk as anybody who has some risk with respect to their access to the social determinants of health, right? So rural and remote communities, marginalized communities, people who use substances, intimate partner violence, and some of the exceptions to that would be athletes, and very young and very old people who may be more susceptible to falls, and of course, military veterans. But again, for the purposes of our discussion, we're working with folks who are in general at very high risk for brain injury. Now, I show this slide because it's really hard to quantify, like, how well do people recover from traumatic brain injuries. And I really want to illustrate here, if you look at this, these are outcome data that are related to people who were hospitalized for rehabilitation after a brain injury, so moderate to severe injury, probably at least. And these are the 5-year outcomes. And it's not just one and done necessarily. Folks, after they're discharged, about 22% of them pass away, 30% become worse, 22% stayed home, and 26% improved. This is a large population-based study that was conducted by the CDC in the States. But I think the information translates very well to Canada. And it's one of the reasons we justify looking at the traumatic brain injury really as a chronic health condition. The nature of the impacts change over time. There are some late occurring difficulties related to, for example, endocrine function and seizure susceptibility, and also the ongoing problems with emotional regulation and mental health and cognition. And those impacts have an evolving impact medically and psychosocially. And we really have to be thinking about managing traumatic brain injury and all acquired brain injuries as a chronic health problem. And doing everything that we would for a condition, say diabetes, where we're following people over time, we're checking in, and we're giving them the resources that they need according to the issues that are appearing. Um, so most people with mild traumatic brain injury recover no problem. What we have to think about is that with the multiple mild injuries in the population that we're talking about, many of them are never seen by a medical professional. If you think about the situation with folks who are, for example, in intimate partner violence situations, they may have a number of brain injuries that never come to medical attention, and those impacts accumulate and they may have an impact on your ability to provide service. So when we think about the long-term outcomes, and as you're gathering history, you're going to be thinking about how recent the most, how close in time the most recent brain injury was, because there is a trajectory for improvement generally after a brain injury, but there also can be longer term longer term difficulties that arise, and also age and injury. And I don't have time to really talk about that relationship very well, but we do know that early injuries often have an outsized impact on and cognitive development, and then psychosocial factors, including mental health and later substance use. So injuries before the age of 12, in some research before the age of 15 are associated with a greater risk for those long-term negative outcomes. And as I was talking about the cumulative effects of these multiple injuries and whether these injuries might be occurring so close in time that an individual doesn't have a chance to recover. And then also, it's not just the injury, but it's the brain that's injured. And this is really relevant for this particular group, which is that many of the clients that you're working with may have other comorbid conditions that affect their brain function, and having a brain injury with that may have a synergistic effect. So other neurological conditions or other chronic health conditions can have an impact on outcome. In broad overview, there are a lot of really good reasons why traumatic brain injury or acquired brain injury has such a strong intersection with mental health and substance use disorders. And one reason is that intoxication increases the risk of having a brain injury. Every fall, every overdose increases the likelihood of lingering cognitive impairment. And the nature of brain injury itself, and I'll try to give a quick explanation of that, actually can lead to an exacerbation of mental health and addiction symptoms. And the results of brain injury may make it more difficult to get treatment. And that's, of course, what we're trying to address today. We're going to talk a little bit also about how substance use itself creates an acquired brain injury. So this is just a really broad overview of a number of studies that look at the frequency of people with a lifetime history of brain injury in different kinds of settings. So really nice research done in the States using a brief interview that gets lifetime history. And what you find is that about a third of all people will say, yeah, I've been hit on the head, but maybe I didn't have a loss of consciousness. I was hit hard enough to maybe get woozy. About 22% will say, yeah, I had a brain injury or a mild traumatic brain injury and I lost consciousness, even if it was briefly. I know I have. So it's like 1 in 5 of us. And about 5%, and it's actually somewhere between 3 and 6% if you really consider how these data were collected, will have moderate to severe injuries, right? And if you look down the list there in substance use treatment, that's double. In psychiatric inpatients, it's 2.5 times. So it's now half of everyone has that history. Prisoners or people in custody and homelessness. And you can see that the number of moderate to severe brain injury climbs until you get to people who are unhoused, and then you get up into 25%. But one of the really important things here is that there's also an accumulation or an overrepresentation of people with moderate to severe injuries being served in settings that are designed to address substance use disorders, psychiatric inpatient settings, and in homelessness services. And when you get to the most complex of the individuals that in terms of groups that have been studied, and this would be concurrent disorders programs with severe mental illness, about 80% have one traumatic brain injury, about 61% with loss of consciousness, 24% with at least one moderate to severe traumatic brain injury. Now, I'm quoting one study, it was McHugo et al. Here, but there are other studies that have very, very similar findings. And it was certainly backed up by some of the data that we collected at the Center for Addiction and Mental Health. The extent of the brain injury history in this study was related to the severity of substance use, and also in our study and in this study, the severity of psychiatric symptoms, the likelihood of being of criminal justice involvement, and a greater likelihood of homelessness. And they were also more likely to report adverse childhood experiences, PTSD, and present with things that we might refer to as personality disorders, antisocial personality disorder, bipolar, not bipolar, um, uh, borderline personality disorder traits. And those were all related to this history of traumatic brain injury. The earlier the first injury, the more likely there was to be the presence of psychotic symptoms. So, and when they talk about early first injury here, we're talking about before the age of 15. So we really can think about history of brain injury as a marker for symptom complexity, right? And when you're gathering lifetime history of brain injury, and again, there's instruction in how to do that in the toolkit. And if I get time, I'll touch on that briefly. Loss of consciousness, multiple injuries, early injuries, and more severe injuries are going to tell you, maybe I need to modify my approach because there's neurocognitive impairment. Now, very briefly, why does TBI have such a big impact on behavior? Well, it's because the frontal lobe structures are most vulnerable, and it's those structures that are related to the moderation or modulation of behavior, planning, and problem solving, all that good intellectual or good executive functioning that allows us to have goal-directed behavior. Also, memory, because the temporal poles are at risk, and the functioning of the amygdala, which together means that there's a perfect storm for emotional dysregulation because of changes in the way that the limbic system or the emotional machinery works, and all of the connections between the emotional machinery and the frontal lobes. One of the reasons for that is the anatomy of the skull, how, the anterior, the middle, and the posterior fossa are constructed. When the brain gets forced around, it either, stops tissue, some tissue while other tissue keeps moving, or there's a torsion effect, and that can result in axonal shearing. So the shearing apart of neuronal connections deep in the white matter, right? And all of this is occurring through the anatomy, the neuroanatomy that's responsible for response to reward. And it's, of course, if you're working in addictions, you're familiar with illustrations such as these that talk about the impact of substances on behavior and cognition. So we have these axonal shearing injuries that create problems with functional communication between different areas of the brain. And they may show up on imaging as tiny little white matter changes or petechial hemorrhages, but they show up much more clearly on functional neuroimaging, where we're watching how neurons actually work with each other. And just really quickly, these are two functional imaging studies that are a form of tractography. So they're looking at different neuronal tracks. And you can see in this normal brain, the nice corpus callosum that connects both sides of the brain. And you can see here after a moderate to severe brain injury, how it might look anatomically intact, but functionally there's a reduced connectivity between the cerebral hemispheres, and then also less organization top to bottom and front to back in terms of those connections. So traumatic brain injury really has a disproportionate effect on emotional regulation, executive functioning, and memory, in part because it creates a situation where the brain just simply isn't working as well together, the parts of the brain, in a coordinated fashion. And that's some of what happens actually with substance use, in particular when we're talking about opioids. So it's probably very familiar to you what the definition of a substance use disorder is. And ASAM has really incorporated this idea that interactions among brain circuits, genetics, and the environment, and an individual's life experience are what are causal factors in brain injury. And you can see how interactions among brain circuits, if we have a disorder that is changing the way that brain circuits work, you might develop behaviors that become compulsive and often continue despite harmful consequences. And in fact, opioids are like a really good example of how that can happen. And I am such a brain functioning nerd. It's going to kill me to go through this really quickly. But I guess we can return to it if there's time later. But this is an illustration from the Blackman article that's referenced in one of the next couple slides. So if you wanted to look it up, you could. And what you're seeing here is these are the toxic effects. And you can see that they vary a little bit among among drugs. They all include the cortical mantle. Okay, so that's the frontal cortices, but also other areas of the cortex as well. And but they, in particular, heroin and oxycodone have toxic effects on the prefrontal cortex, which is particularly involved in problem solving, and in some cases, the interpretation of reward and the interpretation of emotional responses, right? And we can see that even methadone has an impact, a toxic impact across the cortex. And then, you know, the brainstem and the cerebellum, the brainstem being responsible for autonomic functions in part, but also coordinating sensory information, and the cerebellum, which is responsible for movement, which we'll talk about a little bit later. And so of course you can see it's a perfect storm because these are the same tracks, the same areas that are affected by acquired brain injury. And these are the articles that you know, if you're interested and you get the slides, you can have a look at. They're really nice reviews and talk a little bit about how opioid use disorder and affects the brain, and also kind of an interesting take on how that knowledge can be used to target treatment. The big overview is that there is a reduction in self-control because of how the changes that the opioids make and how the cortex communicates with other parts of the brain. And so it becomes less able to actually accurately identify activities that are good in the long run. And how that works is that the opioid use over time causes changes in white matter. Now, in a normal brain with white matter, learning increases or puffs up the white matter, which is actually the connections between different brain sections. So that makes sense because what you're doing when you're learning something is you're connecting or creating networks for a particular behavior or set of information. We know that like in mental health conditions that there is reduced white matter in some areas related to schizophrenia. So interesting, there might be more white matter in networks that are related to self-referential thought and that are implicated in what we call the default network. So that's where you go when you daydream, or what you use when you daydream, and less in problem solving and in learning networks. So there is a direct relationship between the volume of white matter and what's happening in terms of mental health and behavior. So environmental toxins can have an impact on how well the different neuronal structures regenerate, and how well the white matter can take care of itself and maintain itself, and also too that interacts with behavior. So that opioids make in the brain is that they are known to cause a decrease in the volume of the amygdala, and what that's been associated with, and the amygdala is related to emotional responses, particularly negative emotional responses, and also, and I don't think I have it on this slide, reduced hippocampal volume, which is another structure in the limbic system that's responsible for memory. And so what's reflected in the changes in neuroanatomy is a person who has smaller networks that are related to learning. So that include the reward network along with the conscious thinking or executive parts of the brain. So those get smaller, those learning networks, and what gets bigger are these dorsal networks that are really associated with habit-related behaviors. And that maps on very accurately to the compulsive nature of the behavior. So the person becomes less able to update information about whether or not something is good or bad for you in the long run. Those learning networks are not there to update that information. And so the behavior goes back to the habit networks, which wind up controlling what happens with the individual. And I will just suffice it to say that similar patterns are observed on functional imaging, where we see less connectivity in learning networks, more connectivity or more functional connectivity in these habit networks, and then hyperreactivity to drug-related stimuli, and less emotional response that ordinarily would be associated with pleasure, things like everyday activities that would be pleasurable, less emotional response to those things, and a heightened response to drug-related stimuli. So I'm going to ask you, I'm just going to, and we'll see how well this works, but I'm going to have you just listen for a few minutes to this interview of a young woman. Oops, that was the wrong one. Of a young woman who is who's describing herself as having an addiction to fentanyl. And it's a news report. It's a little bit sensational in its approach, but I want you to see if you can think about about her behaviors in the context of what I've just.
And chin clawed open by her own fingernails because the use of fentanyl makes her skin crawl. I spot her on the Strip, Surrey's infamous drug hangout, and ask if she'll talk to me. She puts cover-up on her raw skin.
So I'm literally just did my mascara and I'm good to go.
Katie settles in to tell her story.
There you go. Perfect.
How she ended up living on the street 3 months ago, addicted to fentanyl.
Well, I've been using, it's actually funny, well, not funny, it's terrible. I have a really addictive personality. I've always been, addicted to something, whether it was shopping or Facebook or whatever. And I did an oxy. I got addicted right away. And then I found a regular dealer and I started picking up all the time. I remember the day the fentanyl came out and my dealer said, I've got these new pills. They're fake oxys. He didn't tell me they were fentanyl because nobody knew what fentanyl was yet. He just said they're 100 times stronger and they're only $5 more. And I was just like, okay, because I was getting a pretty high tolerance at this point.
Oxys, OxyContin led to fake 80s, fentanyl posing as OxyContin. Immediately, Katie wanted nothing else.
I could buy one of these fake 80s, put them into 4 lines, and 2 lines would last me a full day. That's how strong it was. And if I did a full pill, I would OD.
Katie says she's overdosed 11 times, most recently a few days ago. Brought back by paramedics or friends on the strip who have naloxone, the powerful opioid antidote.
Every time I do dope, I know I'm taking a risk. I know that I might die, but it doesn't matter how many times I've OD'd. I still use the next day because the withdrawals are so bad.
Katie has been in the news before. She and her sister attacked by a Rottweiler cross back in December. Katie was badly hurt and spent time in hospital. She says that cemented her addiction to fentanyl. As she talks, blood starts to seep through her makeup.
Katie, you're 22. Why would you risk this?
Well, at first it was just fun, right? It was just for fun. It was just a party drug that, and there's been some things that I've gone through and it helped with a lot of pain. And especially after, that dog attack, I just couldn't stop,
I asked Katie if she worries about herself and her future.
Sometimes. I don't know. I just like to take things one day at a time, right? I'll kind of just go with it and hopefully, hope for the best.
For now, the best Katie can hope for is to wake up.
This program contains subject matter and language that may be disturbing to some viewers. Viewer discretion is advised.
My name. Okay, so, there we go. So when we, let's go back to this. So when we think about Katie's story and we think about her response to it, what are the cognitive concerns? She sounds good. She's talking well. She's answering the questions. What's missing is the executive functioning if you're really thinking about her answers to those questions. What is her ability for future planning? How is her attention and concentration? What insight does she have about the impacts of what's occurring? So some of these impacts are really, really pretty subtle. And I think once you get an eye for it, you can start to see the attention, the memory problems, the difficulties with problem solving, planning, communication, and the poor social cognition. But again, it can be a very invisible neurocognitive impairment because speech is less affected, because motor functioning may only be affected in pretty subtle ways, and there aren't big tells to say that there's a difficult cognitive or mental difficulty. So the changes in self-regulation are a reward system that's tilted in the direction of immediate reward and also becomes less tolerant of distress and less active executive functioning. So you're not engaging the frontal lobe in problem solving or updating your current theories about what's good for you or not. And your behavior becomes more guided by habit or compulsion with less self-reflection. What's really interesting is that these effects do reverse themselves, and recovery is observable with abstinence. Sometimes it's complete, sometimes it isn't, and part of that interacts with what other neurocognitive impairment might be happening, and how many overdoses a person might have had. But there are still lingering impairments as long as a year or 2 years after. A young brain like Heidi's would have a chance of recovering fairly completely if she's able to maintain abstinence for a period of a year or two, and that may require a lot of support during that year and maybe even a controlled environment. But the relapsing remitting nature of opioid use disorder suggests that really there's lingering cognitive impairment in that way. If we look at cognitive impairment broadly in addiction programs, about 20 to 70% screen positive for cognitive impairment. It seems to be higher in these complex clients with comorbid conditions, but the population that's been most studied has been the people who are getting treatment for alcohol use disorders, and in that population, findings suggest between 20 and 50% have cognitive impairment. This is just one example of a study using the MoCA screening, where 1 in 3 patients tested in the impaired range, more common in older clients. Memory was more affected with alcohol than in cannabis. And visual spatial impairments are affected with opioids. And what that likely reflects is difficulty with executive functioning, because those are more novel tasks that people tend not to have you have to sort of think through how you're going to approach those drawing tasks. And it probably reflects executive impairment. Lots of good growing information about how important it is to be directly addressing cognitive impairment and executive impairment in particular when we're looking at addictions programming. I'm already behind time already, partly because of my lack of discipline, and partly because of the difficulties with technical stuff. So I'm going to speed up a little bit to make sure that we get to the intervention. But briefly, with overdose, your brain is kind of an energy hog, and it's 2% of your body weight, but it uses 20% of your oxygen and 15% of the blood pumped to your heart. And it really only takes a pretty short period of time before inadequate oxygen is affecting brain injury or creating a brain injury. After about 1 to 2 minutes, brain injury can start to occur. 6 minutes, there's frank death of brain cells as opposed to just maybe an ischemic response. And then often at 10 minutes, you start to have a likelihood of brain function not returning. The impacts of overdose are greatest in the areas of the brain that are most metabolically active. So that would include the hippocampus. And as I said before, that's an area of the brain that helps to consolidate or index memories. And they are a part of your consciously aware memory. So it helps you to remember what's happened to you, episodes, and information that you may have only heard once or twice. And then the cerebellum, which coordinates movement, but it also coordinates thinking. So like things like mental arithmetic or kind of cognitive routines that you have for automated cognitive activities. And so very often, 2 of the big impacts of hypoxic episodes are cognitive slowing, so reflecting that reduced coordination, but also because of white matter impairments related to the anoxic episode itself, and then also difficulty with memory consolidation. So people who are having difficulty remembering recent events. I'm going to skip over playing this video for the sake of time, but if you do, you can Google yourself hypoxia demonstration. And in the demonstration, they go from 99% oxygen saturation to 60%. And what you see the reporter doing is that he's unable to problem solve, his coordination starts to go, and what he describes is a feeling of euphoria. So he's not in distress at 60% saturation. And what's interesting is he just doesn't respond, hey, it's time to put your mask back on. And what I draw from this is that it's possible to have a prolonged hypoxia, if a person is pretty sedated as the result of their opioid use, and have some of these impacts. Now, with hypoxia, you might get, depending on the severity, temporary or more permanent memory loss, reduced coordination, inattentiveness, poor judgment, and euphoria with a complete lack of oxygen to the brain, coma, seizure, and brain death. Now, when we've tried to look at okay, so how much damage does occur when a person has an overdose and then is brought back with naloxone? And it's really difficult to conduct that research. You'd really have to look longitudinally over time and compare individuals to themselves. because this population has so many potential sources of neurocognitive impairment that would be observed on testing, including the substance use itself, but also chronic diseases, and traumatic brain injury, and then how many overdoses they've had. What was that additive effect? So if you look at between groups, you really can't answer that question. So I'm not sure if we're really going to know exactly how much each overdose nicks off of a person's cognitive function, but there is good evidence that it does erode memory, attention, and executive functioning. And I will point you to this reference that you can get from the slides. We know that non-fatal overdose occurs probably for every fatal overdose that's hospitalized. There may be between 15 and 30 non-fatal overdoses. Most of them don't get medical attention, likely. TBI risk, TBI history increases the risk of overdose threefold. There's a cycle that can develop where cognition is impaired, and you may have multiple repeated overdoses because an individual is less able to moderate their substance use in a safe way because of their cognitive impairments. These are the risk factors that you're probably already aware of for having an overdose, but I will just point out that a history of overdose is really an important common risk. An overdose definitely can result in a range of symptoms, but what you're most likely to see in your practice are memory loss, impaired judgment, and slow cognitive processing, which if it may be hard to tease apart from a lot of things, including intoxication. So when you're observing people in your practice and you're thinking about cognition, we often use this flow of cognition to sort of conceptualize how to make your observations. Each of these cognitive functions builds on one another. So you have to be alert before you can pay attention. You have to pay attention before you can process information, whether it's efficient processing or not. It has to be processed before it can be remembered. And it has to be remembered or held in memory long enough for you to use that information in problem solving or planning or any other executive function. So when an individual is having trouble with resource allocation in their brain, in other words, focusing attention and creating alertness, right? You may get inattention and lethargy. And that's often present, especially immediately following overdose episodes. If there's difficulty with sustaining attention, then what you'll observe is tangential speech or behavior that appears disorganized, having difficulty finding objects, becoming easily derailed from desired activities. And then difficulty with monitoring and switching attention. So problems with gleaning information from the environment, catching on to rules, a tendency to perseverate in unsuccessful strategies, and difficulty in sort of zooming in and zooming out when you're looking at your life problems. And we saw this with the example on video. I mean, she's saying, I'll just hope for whatever comes. I know I might die. It sort of speaks of difficulty in prioritizing and seeing the long-term impacts of behavior. With memory, what you'll see mostly is changes in declarative memory, so a person's ability to fluently recall information or episodes that are happening, but they will still be able to learn new motor skills, learn new habits, and they will definitely have a hangover of an emotional response. So although they may not remember everything that you've talked with them about in your session, they do tend to remember how they felt about you when they were in the session. And I think that's one of the kind of neurocognitive underpinnings of why motivational interviewing becomes so important, and being positive and caring to help a person to have a positive association with the intervention so that they will return and maintain their progress in an intervention. So, as I said, declarative memory is most vulnerable, and this implicit memory or the muscle memory is much less vulnerable. Executive functioning is very vulnerable and includes planning, mental control, difficulty with awareness, behavioral self-management. And what you see with impaired processing of rewards and changes in motivation are a pattern of behavior known as delay discounting. So people will be impulsive. They won't see the value of delaying gratification. And they'll be unable to predict their own behavior. So there's a big gap between what they say they want to do and what they do, because they'll have a tendency to be derailed by the thing that's most immediately reinforcing or captures their attention. They may have difficulty initiating behaviors, so they seem to forget their intentions or just neglect their goals. They may have, perhaps when you talk to them, you can elicit it, but on their own, it doesn't occur to them to have a value in planning ahead. Oftentimes, you'll see poor hygiene because a person will fail to initiate those activities. And they'll talk about a lack of pleasure in typical activities. Again, remember, there's less emotional responsivity to normal pleasures, and then repeating mistakes or compulsive behaviors. What you'll see with problems with behavioral planning are difficulties with recognizing the need for a plan. And we certainly saw that in our video example. I guess I'll just wait and see what happens. So impulsivity, and you might see frank avoidance or disorganization. Again, in the context of, say, a motivational interview, you may be able to elicit that and help an individual to consolidate it. But it's not something that's naturally occurring without some environmental support to have it happen. People will have difficulty creating plans. They'll seem erratic, disorganized. Their belongings will be disorganized. And they'll have trouble setting priorities. So they'll have poor foresight, difficulty setting goals, and seem directionless. Difficulties with self-regulation occur because self-regulation really relies on a well-coordinated brain where the limbic system is actually in good communication with the frontal lobes, and resources are being allocated in the brain according to what the real priority should be. When we think about affective processing, that is not necessarily simply a psychological issue, but may occur as the result of these disconnections. And you may see mood swings, blunted emotion, inappropriate affect, or flooding or freezing when an individual is overwhelmed. And they may have difficulty using their emotion to guide their behaviors. So there may be less of a blunted response to problems that aren't substance related. And so in the absence of that blunted emotional response, they have nothing to inform their behavioral choices in the future. And again, that what that causes is a behavioral pattern like delayed discounting. And something that I think is really important to consider when we're thinking about shelter situations or partner situations is it's a very complex cognitive exercise to use theory of mind, to think about what another person might be thinking about, and to have empathy. It requires a lot of bandpass. And so many people who have this kind of executive impairment will appear to lack empathy. And they'll also lack appropriate emotional response and seem to be sort of oblivious to some of the risks that they're undertaking. And they may have poor communication pragmatics. So interrupting, starting stories kind of in the middle, assuming that you have information that you really could never have. And all of those things are related in part to how a person processes social and emotional information. So brain functions that can be affected by brain injury and substance use are cognitive, they are behavioral, they relate to communication, and they relate to social communication. So what you're going to see are people with a bigger gap between what they say they're going to do and what they do than maybe other clients. Difficulty engaging because they have trouble finding services, making and keeping appointments, and keeping up with program requirements. Much more likely to drop out prematurely, and much more likely to be seen as non-compliant or unmotivated. So what do we do? We assume the clients are doing the best that they can. And we think, could this be a neurological problem? And what can I do to accommodate? So we're going to think about what is their capacity for self-management? Is there cognitive impairment? And what are the potential structures and supports that I can do that would help a person to function more appropriately and more effectively? So key evidence-based practices. I'm not going to get a chance to talk about this in detail because I want to wrap up in just the next few minutes. But what we know is that incentives or contingency management is very effective for stimulant use, particularly in opioid use disorders. It's one of the fewer or lesser used of the strategies. There is, and I'm going to fly through these slides, there is evidence, particularly in acquired brain injury, that it's effective. And one of the reasons it's effective is if you're offering an incentive, it gives a person a clear reason to modify their behavior. When their reward system is difficult and they're not updating information about what might be helpful or not to their future self, they may need that additional sort of spotlight on what might be an effective behavior. It reduces the cognitive load of making that choice. And then I would also point out that programs that are looking at the substance use in a behavioral way, like community reinforcement and family training, are also very promising practices in this group. So again, outcome studies suggest that, you have to get people to come to treatment and stay to treatment to benefit, and the characteristics for dropping out are cognitive impairment. So we really have to be thinking about modifying this if we want to capture folks. And one of the prime targets is going to be associated with therapeutic alliance. And we know that one barrier to therapeutic alliance is if a person is having difficulty understanding what's happening in a situation, doesn't remember what's happening, or isn't able to remember the context or the content of a conversation, but walks away feeling shamed or angry. So we really, to capture this population well, we really have to be thinking about how well are we developing that and therapeutic alliance. Sorry. If there's administrators who are looking for recommendations on an administrative level for how to incorporate some of this care, my colleague Tim Godden and I just came out with a paper in Healthcare Quarterly, and we talked about our main recommendations, which are screening for brain injuries, supporting clinicians, supporting partnerships with community agencies, and considering the development of program structures and behavioral interventions that have been shown to have benefit for individuals with cognitive impairment. And that's specifically giving consideration to providing or to using contingency management in a creative way. So again, here are the main resources that I've been talking about. There's some other resources, and we've talked a little bit about recommendations for service providers. I'm not going to get a chance to talk in detail about screening, but that information is in the toolkit. And we recommend the Ohio State University method. And there's some quick screening questions that actually condense that interview. However, I don't really see a need to do it because once you get used to doing the interview, it really only takes about 10 or 15 minutes of time at the outside when a person has a history of several brain injuries to tell you about. There's online training. And there's also brief screening questions related to overdose. And so asking specifically about episodes of overdose, how frequently they're happening, how close together in time, and whether or not the individual is feeling any effects from them. the length of loss of consciousness, and any changes that they've experienced. Another thing to do that when you're talking or interviewing the clients, and this is reviewed in detail in the toolkit, is to be asking them about how they spend their day so you can get a sense for what their executive functioning is like by asking them questions about when do you get up, what do you do about washing and breakfast, and then listening for whether the account is organized and realistic. Do they have routines? Is there anybody at home? Are there any environmental supports that can be brought to bear? And how much activity is planned in the day? And then learning how they compensate. Are they aware of a memory problem? Do they do anything to help? Can you look with them in their phone to see, was your appointment listed there? And then helping them to use whatever resources they have to compensate. So the broad areas of accommodation are going to be cognitive. So it's all those cognitive accommodations like slowing down. Oh, I'm getting ahead of myself. And then the neurobehavioral. The neurocognitive refers to the mechanics of what you're doing. So you're going to reduce distractions, use written materials, slow things down. But the neurobehavioral may change the targets somewhat. You may be working with someone to accept environmental supports because their reward system isn't functioning well and they are very impulsive. Or you may be using incentives or helping them to develop a set of reinforcing behaviors that directly compete with the opportunity for substance use. And you're going to accommodate cognitive impairment by helping them to make specific plans for keeping your appointments, helping them to pay attention by reducing distractions, planning to help them remember what to do, walking through decisions in a way that gives them a choice between a couple of options rather than asking broad open-ended questions, helping them to plan, case management to help with initiation, and then helping them to think about and evaluate their own performances. And you're going to be really conscious of reducing cognitive load. So slowing things down, using routines, setting these clear goals and agendas, breaking down tasks. And again, some of the recommendations for this and examples are contained in the toolkit. These are some of the references related to contingency management. And this was one of the sort of seminal studies. It was kind of small, but it was a randomized control trial that demonstrates that people who have brain injuries really benefit from really even a small single incentive. And the effects of that small single incentive, just a $25 gift card to complete a treatment plan in 4 sessions, changed in the long term a person's engagement with the treatment. And when asked afterwards, they said that they maintained the treatment because they were engaged with their provider. So using the incentive to help people engage and then using engagement to help people change becomes a really key strategy. The rest of my talk is are some modifications for interventions that you might already be familiar with. And again, these are also reviewed in the toolkit. How to modify motivational interviewing if you're concerned about neurocognitive impairment by being more directive, using cognitive compensations during the course of the conversation, making sure that your reflections are sort of simple, using concrete metaphors, and focusing on and then perhaps a target behavior of accepting and using environmental supports. And then if you're not familiar with community reinforcement and family training, it is described in the toolkit. And what that is it's holistic care that's really designed to help an individual to meet their own goals. And to help family members better understand how to talk to individuals about their substance use in a way that will reduce conflict and increase the likelihood of an individual being more willing to accept the care that they require. And it includes a strong behavioral element, which is functional analysis of the substance use, but also includes case management to increase engagement and meaningful activity. At the end of the slides, if you do decide to get a copy of the slides, I have some outcome data from a few programs that that show and the that making these accommodations reduces dropout and improves outcome. And the accommodations are inexpensive. Um, and they may come at the expense of some of the content in the programs, but when you consider that an individual may not be benefiting from the content because they're not staying, it probably is a really good trade-off. And I've been doing some consultation with a few programs in the States where, and I was able to visit one of the programs that uses the program here that I have on the screen, the ACE program, where the culture of the program really improved. And the staff members were feeling really good about the fact that they were understanding an individual's behavior and understanding how they make choices and feeling that they had a way to intervene that wasn't punitive when there were rule breaches or lapses or other difficulties that occurred in the program, but helping to support them to use better executive functioning. And clients also reported that they enjoyed the programming. And the program that I have up here on the screen is the Alcohol and Drug Cognitive Enhancement Program. It's a colleague of mine from Australia who has done some amazing work. It is a turnkey program. It provides a roadmap for including cognitive compensation training in any program that you're working in. It's also really good to look through the materials because you can use it in one-on-one sessions because of the metaphors that they use for understanding neurocognitive impairment and what happens as a result of substance use with simple diagrams like this, like the frontal lobe helps what I should do next. The parietal lobes tell you what's happening now, and the frontal lobes helps to inform your behavior based on what's happened in the past. And metaphors for executive functioning that help a person to actually use metacognitive strategies or thinking about their own thinking to improve their cognitive functioning. And as I alluded to in the beginning, when these interventions, cognitive strategy training and other and mindfulness training and some of these other therapeutic approaches are undertaken, they actually do make a change in cognitive functioning. So they improve that outcome. And as a result, they also improve outcomes from the programming. And this is one of the studies that demonstrates how effective that was in helping to retain people in treatment. I'm going to end on this slide, which is the ABI Navigator contact information. Across the province, there are ABI navigators that are individuals who are aware of what the community resources are for acquired brain injury. They are aware of the intersection between the brain injury and mental health. That can provide training related to brain injury and mental health. They can provide advice. And where it's possible, they can also make recommendations for community resources for direct intervention. But they're a fabulous resource. There's one in every geographic region. And I have included, and I hope it works, the QR code here so you can get this list. If you lose it or you forget about all of this, all you have to do is Google ABI Navigators or look at Ontario Connects, the website that lists social service programs, and you will find your ABI Navigators. And they are a good link in the program to other community-based programs. And I am going to stop right there. Late. Sorry.
No, that was wonderful. Thank you very, very much. What a comprehensive introduction overview of what is a very complex and important topic. So thank you, and I wish you had more time to go through all the things that I know you passed over. For the folks who are very eager, I'm sure, to look at these slides in detail. As long as we have your permission, Dr. Lemsky, we will post them on our website, so folks don't have to worry about the things that they might have missed. I'd like to encourage everyone, if you have a question, please do post it in the chat or raise your hand. Uh, I mean, as a non-clinician and someone who is profoundly unfamiliar with the brain as a physical structure, I am a little out of my depth, but there was you used the word cycle at one point, and that was something that I was thinking about the whole time while you were talking, just about the ways that that substance use and brain injury, how they the effects compound each other, and how difficult that must be, how much more difficult that makes it to approach the problem, and for the person, as well as for the provider, of course, but just how those things are they seem to be compounded. It's not just a simple. It's not as simple as that.
Yeah, if you imagine yourself being put in a position where you're not entirely aware of how things have changed, and you keep doing this behavior that you know in the long run is not good for you, and people around you keep shaming you about it, and you can't stop it. And what a crazy making situation that is, and what kinds of adaptations people make to being in that situation, which we start to call addictive personality, which I think in fact is a way of coping with the disconnect between what I know is good for me and what I tend to do. And my experience is that when you teach people about it when they're ready to hear it, and after having observed their own behavior for a period of time, it's a tremendous relief. This isn't a moral failing. This is a physical problem.
Yeah.
And my experience also with providers is that when they're addressing that problem, they feel better about the intervention they're providing.
Yeah, absolutely. We have a question from Wiplav Lamba. Thank you for the great talk in terms of both description and treatment suggestions. Absolutely. I work in a hospital-based consult service and a RAM clinic. What training would help our organization be TBI capable? What would be the bare minimum? I worry we are under recognizing it and not keeping people who want help stay in treatment.
I think you can kind of cover the basics in a couple of hours of workshop, or just reviewing that brain. WHIP is actually a plant here. Thank you for the question. But yeah, I mean, like a couple hour workshop, or using the workbook. And then there's also, like, if you actually look online, I think there's a bunch of my webinars are out there, and there's other materials from the Ohio Valley Brain Injury for Prevention. They have a little course that you can take for accommodating neurocognitive impairment. Oregon's does too. The Ohio Ontario Brain Injury Association has a little the least you need to know course about brain injury, and those things focus on traumatic brain injury. But there's a lot of lessons that directly apply to the situation with opioid use disorder. But I think it's really fascinating how, the learning tracks get skinny and the habit tracks get fat, and how that reverses itself with the right treatment. I think and how long that reversal takes, and what we need to be doing to help folks navigate that.
One of the other things I was thinking about, as other folks think about their questions, was, and I think this is sort of implicit in or maybe even explicit in a lot of what you were saying, but how useful these accommodations are, not just for folks with brain injury, but for anyone who has executive dysfunction, which can arise for any number of reasons, and how these strategies are really targeted to facilitate people to stay engaged, and to actually present them with things that will actually help them.
Yeah, I mean, it kind of dovetails with trauma-informed care, right? I mean,
Yeah.
what we know is that when a person is feeling anxious or distressed, their frontal lobe functioning turns off, and they go into fight or flight,
Yeah.
or freeze,
Yeah.
right? Or conciliatory behavior. And they stop thinking it through and they go to one of these stereotyped options instead of being able to stay in the moment and address whatever the issue is. And so um, putting a cognitive lens to that can help just simply by slowing things down, writing things down, repeating things, and bringing recognition to the fact that's just a part of how our brains work. And not to worry, we can compensate for that.
I'm very interested in the Australian the metastra the I saw in the slide the sort of array of characters, the way that the executive function is sort of anthropomorphized, and these are the different functions, and yeah, that's it, the executive team. I think that's such a creative and useful way to frame it.
Yeah, and it gives you this chance, and what they were telling me in the programs that I visited, is that it gives you the chance to say, oh, let's think about your emotion regulator, you know, that part of you that is the motion regulator. What's happening now, and how can you engage that? Um, yeah, and if I there's little videos on how to run the sessions. It's just completely turnkey. It's amazing. And I'm just remembering you told me to turn off my share, so I'm going to do that now.
No, this is fine. No, that's fine. So and we've got about 7 minutes left. I know, was there anything that you'd really like? Oh, I wish I had spent another couple of minutes talking about this one thing. Is there anything that you wanted to sort of go back to?
Well, I mean, if people are not too bored by it, uh, I'll talk a little bit about what that toolkit is. Um,
Yeah.
it's pretty extensive. Let me share again. It's a pretty extensive document, and it includes screening, recognizing and accommodating TBI, recommendations for service delivery, and then a bunch of resources that can be helpful to expand on some of the sessions. It talks about patterns of injury, and it's written in a tabular format, most of it. So you might see a problem, some examples of that issue, and then some strategies that you might employ. The idea not to be too prescriptive, but to give a person ideas about how to address it. Um, and then taking a lens of how do we help people to meet the responsibilities associated with participation in treatment. So how do you functionally help people with missing appointments and not completing assignments, not assuming that it's a lack of motivation, but how do we help people to plan ahead, to get done what they need to get done to participate? And then also some suggestions for care planning if you're working in different kinds of settings, about how to include goals for cognitive compensation into a care plan. And then the Subi workbook, I don't have too many slides related to that. It's an MI approach. And what's nice about it is it provides you with that written component, and it's simplified. So it just sort of gives you an idea of what it is to communicate at a fifth grade reading level. And then you can have, there's self-assessment there. So you're not asking a broad open-ended question, but you're kind of using that eliciting thing that we and making it kind of a multiple choice question that can then lead to sort of more open-ended conversation. The chapters are really short. They're only a couple of pages. It's not exhaustive. It can be used as a treatment program. Doesn't have to be. You can just use what you want, modify what you want. It's there to be used clinically. And then this is a really cool website, The Brain from Top to Bottom. Again, I would lose the notes if I got them, so I would just have to remember to Google The Brain from Top to Bottom. It's from McGill University, and it really kind of goes through some of the neurological, the neuroanatomy kinds of information, and at whatever level you're interested in learning about it. So they have, beginner, intermediate, and advanced. Oops. Yep, that was that.
Great. We got another question in the Q&A here. So thinking of screening women in a criminal legal setting, what screening tool would you recommend that would best incorporate both IPV and overdose events?
So I would use the overdose questions that I've got, and I would look into using the Ohio State TBI identification method because it's like a big form, but once you get used to it, it's really easy to do. So the step one is you just sort of ask these questions. They're kind of long stems, so they give you this chance to say, in your lifetime, have you ever been hospitalized or treated in an emergency room? Um, think about any childhood injuries you might have had. So you're really giving a lot of cues to elicit the full information. We know that it's much better than just saying, "Hey, do you have any history of brain injury?" Because people don't know what might be involved with that. And so it goes through all of these questions. They include, hitting your head or neck, being hit by someone or something, being shaken, and so they don't specifically reference IPV, but the questions were formatted so that if a person wants to disclose that history, they would be cued to do so. Um, and I know in an intimate partner violence context, there's a little bit of diagnosis threat. People don't want to be necessarily diagnosed with a brain injury because it may um, reflect badly on their ability to provide evidence in a case or um, maintain contact with their children. So you have to be kind of sensitive about when, where, and how. But this has been used uh, in custody, such in criminal justice system, in prisons and jails, and it's been validated for use for that purpose. And then you can add those specific questions. And again, if you just Google brain injury screening or you go to brainline.org, there's a little course there, and it just teaches you how to use it.
Great. Thank you. Well, we're coming up on 8:30 now, so I'll take the opportunity to thank everyone for attending and thank Dr. Carolyn Lemsky so much for that extremely interesting presentation on something that is really important, and I'm sure it affects a lot of the patients that people see here.
Thanks for inviting me and let me babble at you. I appreciate it.
It was wonderful. Lori has put the link to the session evaluation in the chat. Thank you, Lori. In addition to that, we will be sending out by email a mid-webinar series evaluation, which will be about all of the talks that have taken place so far this year from January up till now. So we will be very grateful to have your input on that if you can. So once again, thank you all very much for being